Hello and welcome to another episode of A Dose of Digital Health, where I'm really excited to be talking and chatting with Dr. Bharan Kumar. So Bharan, I really want to start off by knowing more about the Bharani Medical Centre. It's a lovely centre. Can you tell me a bit about the history of the centre, how you ended up here?
Okay, so yeah, there's a huge, colourful history to this. So Bharani Medical Centre was started by my father in the early 90s. So my father came to Slough in the late 80s. He trained initially as a neurosurgeon. He's still practicing today. He's a senior partner, and he's been a GP for now about 35 years, somewhere around that. When he came to Bharani Medical Centre, he came to Slough. He started as a locum, and he took over from the partner who had to retire due to health reasons. Bharani Medical Centre was a small surgery consisting of 2 sites, and at the time we had 99% of our patients were Pakistani origin, mostly first generation. And we still have that statistic to this day as well. My father started here. He actually learned languages like Urdu and Punjabi in Slough.
That's incredible.
He wasn't formally trained that. He taught those in India, and he carried on. And we've gradually expanded over the years. So we have a couple more sites within Slough, and we have a couple of more sites in Maidenhead as well that all come under the Bharani Group Practice brand.
Okay, so you're spreading out.
We're spreading out, so we've taken over and we've expanded, and we're also part of a primary care network, and I'm the PCN director for that, and that's Shape Primary Care Network, which is based in Slough.
Okay, great.
Yeah.
And tell me a bit more about your community. So you said 99% of the patients here were first generation Pakistani.
They are.
What does that makeup look like now? What in terms of an immigrant population, or a first generation or second generation population? How does that look?
Yeah, good question. So we still have 90% of our patients will still be of Pakistani origin, I would say. We have lots of Indian patients as well. Slough is a very, we would call it an immigrant hub, and it's traditionally been an immigrant hub from the 50s and 60s, with different waves of immigrants coming into Slough every so often, mostly because it's got cheaper accommodation and really good access into London. And you see where we are at the moment, the train station is just up the road. Yeah. So that's why we have different waves. So we've had some Polish population as well. We have different Eastern European. We've had a few patients coming from Ukraine now, and we also have the travelling population as well. So we have that makeup, and we've also seen the Anguillan population as well. So we have multi ethnicities really. Still lots of first generation. So people who have come to this country for the first time, and we are their first GP practice. We still have lots of those type of patients coming in.
Okay. So that's really interesting. It's this big transient, isn't it? And I know Heathrow Airport's not far either.
No.
So there's a lot of movement around generally, isn't there?
Yeah, absolutely.
And, in terms of the challenges that presents here, will be quite unique to Slough, I imagine, this area, or they're replicated in other parts of the country. What sort of challenges? A GP recently told me they're not challenges, they're opportunities. What sort of opportunities or challenges does that present to you?
So I guess we have to look at where our patients are coming from, and they're coming from parts of the world where there isn't a strong primary care system. So going to a GP when you're well is an odd thing. Going to a doctor when you're well, they often go to GPs when they're unwell, which means we have a huge demand for minor ailments, or on-the-day demand for things which we would consider minor ailments here, but in those countries they may consider them major. And I'm going to give you an example. So here, if we have a cough or cold, traditionally we may self-manage, we may visit a pharmacist for a few days. But if you're from an area of the world which is deprived, you may see a cough, but you may see more often than not a cough has then transformed into pneumonia and death. And it's that first symptom of a cough then sends a red flag into your brain that I need to access help now. So first of all, there's a lot of education we have to do with our patients and really empower them to maybe think differently, and to support them on that journey as they learn to educate around education and self-help, and actually lowering their anxiety levels. around things like minor ailments, but also getting them to understand the power and importance of preventative medicine. Things like diabetes, which we have a huge population, 10% of our patients are diabetics, which is a huge number, right? Huge number of hypertensive patients, huge number of patients who have heart attacks and strokes each year, and getting them to engage in preventative medicine is really important, because although Slough is an immigrant town or immigrant hub, it's a really hard-working town, and I think a few years ago it actually won an award for the hardest working town. Okay. So although it's an area of deprivation, people are often working 2 or 3 jobs, they're travelling into the city or different areas. And that's getting them to prioritise, and that's really important, why they're working for themselves, their families, to better themselves, but getting them to prioritise their health and trying to explain to them that, hey, if you prioritise your health, you'll be here in 20, 30 years and you won't have all the problems that in later life. And that's a really big part of it, actually, getting them to engage. And that translates to them coming in for reviews, engaging with us when they're well. And my role, particularly with that, and where the opportunity is around that, is around digital health. Why? Because actually then we can start to communicate with our patients so we're not interrupting their lives too much. And blood pressure is a perfect example of that, actually.
Okay, that's interesting. You've already gone straight to digital health, which was my next question. So the challenge is, I guess, as you said, is that they've gone from, I've got a cough, I need to go and see someone about it, to you have a cough, you don't need to see anyone about it, you just need to look after yourself. If it gets to the point where you're struggling to breathe or whatever, then you need to do something about it. That's very different. And how you then spread those messages, so that education piece, but also then how you get them to look after each other. And the proactive nature, which is what you're talking about. And then I'm thinking, as you then mentioned, digital health. So this is a dose of digital health. Yeah. So when did you first start to realise, Bharan, that digital health could help you manage and better equip your community?
Pandemic.
Yeah.
Pandemic. I genuinely thought pre-pandemic, I saw the way general practice was going with all the things that we had to do, possibly the lack of resources coming in, and really there wasn't anything innovative around how we engage with our patients. It was the same conversation year after year that I actually thought pre-pandemic primary care was going to go off the edge of a cliff and there would be something new. And suddenly what happened in the pandemic is everything in tech was just unleashed. The red tape was just cut.
Yeah.
And it started with AccuRx, which was a game changer, and the ability to text patients, but then to text patients at scale, but also online consultation platform models as well. So as a Bharani Medical Centre and as a practice, we really took each of those and developed our own way of using them, but not and then we took the patients on the journey and the practice on the journey. And there's examples where we've got it right and we've done really, really well, and then there's examples where actually we are still learning. We think we've made some really good changes, but actually there's lots more work that needs to be done. So for example, things like online consultation platforms, we're probably the first in the area to really take that on. So something called eConsult.
Yeah.
When eConsult first came and promoted their product, they did it twice. And both times I thought, how do I turn this off?
Yeah.
I literally thought, when the guy left, I thought, actually, this is rubbish. And then I thought about it and I thought, look, all I'm hearing from patients is, look, and it's a thing. 8 o'clock in the morning, you wake up, have a fight with the receptionist, try and get an appointment, right?
Yeah.
And if you're working or you've got something else to do, that's pretty poor, right? Actually, that's not really fair, and that's really difficult, and it puts a lot of pressure on our receptionists. So we actually then opened up eConsult, and we started engaging with our patients that way really early on, actually, and we're pretty much leaders in that, and that allowed patients to get that access, not almost throughout the day, but they allowed them to not having to ring up. They can just do it online, and then we can get back to them. And getting patients to engage in that process was really important. Then we kind of, we stuck with that for a few years, and particularly, and that really helped. That really, really helped, because now we have different access models in. But over the last year, we've kind of really developed that. So now, if a patient uses eConsult, we know that online consultation goes into a smart inbox. So that's monitored. But what if you ring the surgery, actually, and there aren't any appointments that day? Should you ring back? Particularly what would be frustrating for a patient is if you ring the surgery and this needs to be sorted out by your practice. There's nowhere else you can go. It's not like you're having a heart attack and you need to go to hospital. You may have something that needs to be sorted out. Now, there's no appointments for that day, and the receptionist is unable to book you in advance. Maybe there's no appointments on the screen. it would be annoying for you to ring back the next day and say the same thing. It's like Groundhog Day.
Yeah.
So what if there was a way to capture that information as well and feed it into the same inbox that actually your online consultation has? And now we have that facility as well.
Okay.
So now we've taken our receptionists who are now care navigators into a journey of actually, if that's happening and you're seeing that patient contact you and you know they're going to call you the next day, capture the information, and we fill in something called an e-light. And it's done in a standardized way, similar to an online, it's similar to a full e-consult, but you just ask us just a few questions and it gets fed into the smart inbox. Okay. All of that I can triage on my phone.
Okay.
Do you see what I mean?
Yeah. So no one's missing out.
No one's missing out.
Yeah, so you can think, right, let me just have a quick look here, and you can look for some red flags.
You can look for some red flags, but actually you can triage throughout the day and you can see, well, actually that person can wait maybe 2 or 3 days, or that needs to be dealt with, you know, in 24 hours, or maybe that patient needs to see that specific GP, so you put it in for 4 or 5 days, but you can start to indicate, and then you can get through more volume.
Yeah. And
the idea being in time that patients then won't feel as frustrated. Then we start to use population health tools. Now, we can use population health tools for lots of different things, but for general practice efficiency, I want to know that my proportion of patients who are at risk are getting the access. So actually, if a patient's high risk, and their numbers, and in Frimley we have a P&G rating, but if they're higher on that scale, our care navigators have already flagged that that's coming up as a 10. So basically, whatever they say, we need to make sure it's captured in this e-light, so that actually then they're not having to call back the next day, because if you're high risk, you're probably going to call back next day anyway, therefore just fill in the information. So this is the journey which we're taking the practice on. Now I say it so confidently, right? I'm like, oh, it's definitely work. It's not, because, you know, unfortunately it is the NHS. There's only so many appointments available. There is going to be a wait. We've seen with secondary care, the waiting lists are high, and we're not going to get it right every time, but that's the ambition. And over time we want that to grow, and we want that to be the new way of working. Yeah. Really.
And does the introduction of e-light along with e-consult, is that, because I guess if people are at 10, they're going to go to A&E potentially.
It depends on the symptoms.
Yeah.
Yeah.
Have you seen it? Have you got any stats to back up the fact that they, because of e-light, because you're looking at that kind of throughout the day, that they're maybe not, and maybe many people aren't going to A&E?
So no, not specifically with that, and I think it's a really good question, but I'll challenge it in a second. So we don't have stats to say that how it reduces A&E tendencies, but we can say that actually these people are only contacting the surgery once, where they may have contacted 2 or 3 times in the past. So that's really important. So they're getting better access, and we're not just using the high risk. So you can be a high risk patient, but you could just cut your finger. So it's all about the symptom. You have to combine it with the symptom as well, and we make it very clear that actually if you've got a problem which is an acute emergency, then actually that supersedes it. So chest pain, for example. You know, I don't care if you're a low-risk 40-year-old gentleman or high-risk 85-year-old, you have to treat it the same way. Chest pain's urgent, right? So you may need to go to A&E. If we want to talk about A&E, this is what I've been doing for the last 2 years, right? So I'll give you a story. So this was about it's longer than that. This was about 2022 now, I want to say. This Monday, about 10 GPs in the surgery, right, all working from about 8, including myself, to about 8:30. I got home at night, 9:15, right? I got an email from the medical director of the Frimley. She said, "You're going to get an email. Don't get fiery, basically." and it was from an A&E consultant that day in Wexham, and she'd emailed saying Bharani Medical Centre has been flagged as one of the as someone who's basically sent too many patients to A&E that day. There's some, I don't know which word she used, but basically a few of my patients have gone to A&E that day. And she's flagged, and she sent an email to the medical director who sent it to you. The medical director was very cool and calm and collected. She said, look, you have to approach this calmly. She said, ask for NHS numbers. So I did. I asked for NHS numbers, and the email, I never heard from them. I'm going to hear from her again. So what I assume what happened was this A&E consultant, very hard-working people, they must have gone on the floor because of the volume of patients, and said, oh, let's do my randomly controlled trial by asking this
so where are you
from, Bharani? Where are you from, Bharani? Where are you from, Bharani? Right, that means, people, Bharani's red flag, right? There you go. So that was it, it prompted the email. But these things matter, right? So obviously she's had a long day, she's frustrated, whatever, right? My patients, I mean, I'm 2 miles away from A&E, happen to go to their local A&E because they are there, right? What can you do? So apparently I'm the flagged up practice. But it got me thinking. It got me thinking, look, how do we challenge this? How do we look at this data in a meaningful way? How do we, you know, I don't want to have this, one thing about me, I hate having the same conversation twice, right? We have a conversation, we deal with it, we move on, right?
Yeah.
Because when I started in Slough, which was 2015, there was a period from 2015 to 2020. It was like the same conversation every year. And you can almost predict it. Oh, okay, we're going to talk about A&E attendances. We're going to see some meaningless data. Fantastic, right? What are we going to do about this? So how do we challenge it? It was around the same time I met a chap called Mark Selman. He's the CIO of Frimley. Okay. Very, very intelligent guy. And we sat around here. This was one evening in December. Everyone was saying to me, Bharan, you should meet Mark. He's got a lot of ideas. Emailed Mark. Said, Mark, should we ever meet for the first time? Mark's got a very similar background. I think he started in the NHS in really humble beginnings, did loads of stuff, and he's worked his way up. So he's got really good knowledge of all, primary care, secondary care, all stuff. Really good relationship with GPs. So we sat around him. It was around December time. It was around the Christmas kind of period. Sat around in the evening, and he showed me the Connected Care platform, which you may or may not know is really a shared care record with a PHM element to it. And there was one page, and he was looking through it, and I said, "Oh, stop there. What's that?" And he said, "Oh, it's not very interesting." I said, No, it is. Let me see it. And what he could show me is that he could see which of my patients were in A&E in real time.
Really?
Yeah. And I was like, whoa, I want this. But it was really rudimentary, right? So it had the NHS number and it had time. I think that was it. NHS number and time, and the fact they were in A&E, because you could filter it by ward. So that's all I worked. And I was like, I need access to this. So the next day I took it to one of my lead receptionists, my business manager, said, check this, right, look what I've got. And there were about 3 patients or 4 patients in A&E, it was 9 in the morning, right? And I said to my lead receptionist, I said, listen, why is this patient in A&E? Because we have to look up the NHS numbers on EMIS, look at the patient and say, like, this patient, why is it in A&E? And she knew. She was like, no, he called and he had chest pain, so we had to go there. Okay. This person's already got an appointment, don't know why they're in A&E. Like, she knew, like, 3 out of 4 patients, she knew exactly why they were in A&E. I thought, this is amazing.
And this is via the connected care.
This is via connected care.
Yeah. Okay.
So,
which is unique to Slough?
Unique to Frimley.
Unique to Frimley.
It was at the time unique to Frimley. Okay. Now it's moved into Bob.
Okay.
Yeah. And the way connected care work is a PHM tool. It's built by GraphNet, and the connected care team basically edit it, develop it further, and you can use it for all kinds of things. So this is just one page. Yeah. It was actually built for district nurses, believe it or not. It was built for district nurses to see which of their patients were in A&E, but I don't think it was ever used. Okay. So for 2 weeks, this was over Christmas, I just started looking at it all the time. I started to watch this.
It sounds like gamification.
It was amazing. and obviously, let's talk about pandemic. They gave me 2 screens. What do I do with the other screen, right? I put this on there. And it was amazing. And I remember I did this little trial. It was a trial for 2 weeks of looking at those patients and contacting them. And I started contacting the patients who were in A&E. And the ones I started pulling out of A&E. And I remember pulling out this man, and he'd sent his daughter to A&E with his wife. And I said, it was ear pain, there was nothing. I said, why are you in A&E? Because, ear pain, I didn't know where to go, and she was screaming, and wife was screaming, so wife booked in as well. And I said, how long's the wait? And she said, 2-3 hours. I said, come and see me. So they left A&E and came to see me, and they were so grateful. And I did it with a few others, but that was the one example I know. I met another patient, same thing as a child who thought it was, there was a problem with the arm, but there wasn't, and it was fine, and it was, just pulled them out and came to come and see me. I don't remember the example so well, but what I remember at the time is they felt really supported. Yeah. They felt super supported because it was as if someone was watching them, and their practice was there at the most vulnerable time.
And you were watching them?
I was watching them, yeah. It was almost like Big Brother, yeah. He was watching them, and they felt like, and the perception of GPs is, we can't access you, but actually we're there when you need us. Yeah. And I think that bond with the practice will never go. Because it was, you can be upset, okay, you didn't get an appointment that day, but you'll always remember, look, at that time, I did try and help, and that's what general practice is about. We talk about that traditional GP, right? Yeah. The GP with the coat, the hat, the gloves, whatever, he comes to your house, he knows you, your whole family. It was that approach which people love, right? You may not have always agreed with what he said, but he was part of your family and he supported you when you were there. Yeah. And that's what I was trying to do with this, is actually you've used that technology to really recreate that. And also it helped me then answer those questions about why people attend A&E, how many of them are appropriate, how many of them are inappropriate, and when we think about, are our outcomes linked to A&E and what are the reasons for A&E attendance is, can I get some real live data for doing that? So started, that was 2 weeks, presented the findings back, then worked with Connected Care and the GraphNet team to develop the dashboard. So now, we can see, and this is going back even 18 months ago, we can not only see the NHS numbers and the time, but we can see the time they've attended, the NHS numbers, the patient's date of birth, we can see the presenting complaint, which is really important, chest pain or or rash or finger injury, but also their segmentation, so whether they're high risk or low risk in terms of the numbers. And now why that's important, because if I'm watching that screen, I see chest pain, I'm like, look, if a 65-year-old gentleman's got chest pain, he's in the right place, to be fair.
Yeah.
But if it's ear pain, like, oh, actually, let me give this guy a call and say,
Yeah.
are you sure you need to be there? And it's really interesting, because the more you know your patients, the more you can do it. My practice manager looked at it once, because we run multiple sites, and I was sitting in this room, and we were having a meeting, and I said, look, does anyone know this guy? He says he's got a chest pain. She said to me, she goes, look, let me call this guy. I know him really well. I don't think he should be in A&E. I don't think it's appropriate. And she rang him. She's actually a local counsellor as well. She knows a lot of people. So she rang him and said, look, what's the situation? It turned out he'd actually fallen on his ribs. So it wasn't a cardiac cause. He'd fallen. And it was a few days ago. And she said, how long was the wait? 2-3 hours. And said, look, Dr. Kumar will see you. You just come now. And she looked at me. She said, okay. I said, no, just get him to get a chest x-ray. I'll request it on the system. He went and got the chest and so come and see me after that. He got the chest x-ray, got reported, saw me an hour later, it's fine. Pulled the patient out of A&E.
So that is quite incredible. I would say more than incredible. So you're actively managing A&E patients from the surgery.
Yep.
Because of the technology.
Because of the technology, yeah.
And you mentioned that it was the pandemic, so COVID-19, that changed the tipping point for really embracing of technology. And you mentioned your father in the late 80s and early 90s, and he had, because of resource and because how things were, he would go out and meet people to homes more often than than you can.
That's how you did, yeah.
So digital health is enabling you, I guess, to almost be part of the community like your dad was.
Yes.
And still is, obviously.
Yeah.
But you're taking it a step further by reaching in, just because Bharani Medical Centre, you're sending all your patients here, and you said, hold on a minute, let me just look at the data. You met with Mark.
Yes,
and he said, I've got this, and you went, that's interesting.
Yeah.
And it does feel like gamification in a way. Yeah. So you're working, you've got a second screen, hold on a second, let me just look at the number, that's something to do with an ear. I can pull them out of A&E, get them to come here, and they're thinking, my God, my surgery really care.
Yes.
Like, they can't see as often as you maybe you'd like to because of resources, but you're able to do that, pull them in, and deal with it there and then. Yep. So you're taking someone out of A&E.
We are, yeah.
You're actively managing them in that situation.
Actively managing.
Absolutely incredible. I've not heard of an example of that ever.
And then it gets more. So then we managed to secure through the director of transformation, system transformation for Frimley RCS, a guy called Sam Burrows. A very, very nice guy. He heard me talk about this and he actually believed, and he was like, I actually kind of believe in what you're doing. So he scrambled a little bit of money together and said, well, can we expand this across Slough? So then we all started doing it. And there was a 3-month trial when we all did it across Slough, and we got the technology in place for all practices. And there was some various elements to it. So it wasn't just looking at the screen and pulling patients out, but it was looking at the screen, looking at the data, and contacting the patients if you need to, and working out, is that patient appropriate for A&E or not? And if they're and we would code it, so we can fill in a template on our EMIS template, and that can be just extracted with some questions. Is it appropriate? Did you contact your GP beforehand? All of these things. What we found, and we've replicated this when I've done it at a small level, when I've done it at scale of a whole town, but also over Christmas I looked at 160 patients as well. Only 20% of attendances are inappropriate to A&E. Okay. And I know there's this figure that we put out there, or this mythological figure that actually lots of people are attending A&E because they can't get a GP appointment. But when you really look at when people are in A&E, only 20% of those patients are patients that actually we should be dealing with in primary care. The other 80% of those patients actually, they're quite suitable to be in an emergency. They should be there, absolutely. Yeah. And again, the technology allows us to make that decision really, really quickly, because we have the connected care element, so we can see who's in A&E, but we also, Frimley Health invested in something called Epic, which is a gold standard shared care record, which means with my Epic link, I can actually see directly into what the triage nurse has said. So although it says sore throat on an 80-year-old gentleman, when I really look in the records within seconds, it's actually foreign body in the throat, which means that, which actually is a bit different to what I can deal with in primary care. There's still education's important, of course, and explaining to patients where all the routes are. But remember, when you're looking at the hours primary care is open and you're looking at what we can deal with in the appropriateness of the clinical setting, you can start to put some real figures to that. And so we answer your question as to, well, actually, have you got any evidence that it reduces any attendances? Well, a lot of the things we do in primary care won't have a significant number of A&E attendances, not because what we're doing in primary care isn't effective, but you're looking at a completely different reasons to why people are attending A&E. What I did want to do, where we're at the stages, is to gather that data and think, well, what is the next step? It's not that we don't want to continue doing this. Of course we want to support our patients. Of course we want to challenge rhetoric and particularly challenge myths that are access is linked to admissions to primary care, because that's important, secondary care, because that's important as an organisation or as primary care to have that knowledge and data. But I don't want people to go to A&E. And instead of creating an environment where you have primary care versus secondary care, it's about collaborative working. So that patient with chest pain or that patient with foreign body and stuff, is there a better pathway that can be created so that the patient's not in A&E, but maybe there's a more suitable pathway or link or setup or service that we can design with secondary care to make it more efficient. So A&E isn't the place where just stuff gets done.
Yeah.
And that's the goal really. But again, technology will be driving that.
Yeah. And the reason I asked about evidence is because we find as an organisation that healthcare organisations themselves ask for evidence of your system and your solution, and it can be quite difficult to do that sometimes because there often isn't the resource within the NHS, resource centre to say, well, look at the number of referrals, and then we can look at the rejected referrals and see if they're appropriate or inappropriate. It's very difficult to do that, but what you can do is use assumptions. So what you're saying there is evidence.
Absolutely.
I can tell you that I could see patients within an A&E setting. We were able to contact them directly and pull them out. Do I have the data or the numbers to look at the efficiency savings? Not right now, but I'm telling you it works.
Yes.
And I think what the challenge is for digital health sometimes is that there are systems, legacy systems even, that work, and when I guess COVID-19, you already had the connected care. You could then use that connected care to help with the COVID-19 pandemic and identify the different cohorts of the patients. But did you have the evidence at the time to that? No, but you just did it. And I think it's clinicians like yourself and some of your colleagues that say, no, we just need to do it now.
Yes.
Because if we wait, we could be waiting a year, 2 years, put a proper pilot together. But you need to start somewhere. It seems to me that's what you did. You saw an opportunity, and I know that you have a high number in this area of patients with hypertension, and you've done some work with the hypertensives. Could you tell me a little bit about that?
A lot of what we do here is tinkering. So we have a problem, we'll tinker, and now particularly post pandemic, although it's time consuming and there's a lot of things we want to rip up. It's fun to tinker and it's fun to rip apart primary care, because that's what I do. I rip apart every aspect, whether it's a financial element, whether it's poor outcomes, and think, well, how can we make this more efficient? And hypertension was one of the original things we did. So one of our surgeries is called Ragston Road surgery. It's on Ragston Road in Charlevy, which is an area of tremendous kind of deprivation, run by two previous GPs who are really hard-working GPs, like the GPs with the coat and the hat, the ones we talk about. Just super hard-working GPs, but towards the tail end of their career, they didn't really embrace QOF and training patients and the digital aspect. So when they retired, I think a lot of these systems weren't in place, and we really struggled over the years to create these systems. And this was a very transient population of patients as well. So we had really poor outcomes with regards to things like hypertension, specifically like 40 to 50%. That was our outcomes, 50%. Whereas you'd be going for 80 or 90% traditionally. The day before lockdown, the CQC came in and hammered us and gave us needs improvement. Quite rightly, to be fair, our outcomes were poor. So during lockdown, with AccuRx opened up, I got the hypertensive register, and I just thought, you know what? I've been a GP for some time now, and I know I go to people's houses and I ask them, have you got blood pressure machines? And they say, yeah, we do. And they're checking it at home. Yeah. But we weren't capturing this data. And I thought, you know what, let me just send this text. And I started tinkering. So I'd see my patient, or call my patient, and then I'd text another patient from this hypertension register. And just a simple text, your hypertension, your blood pressure readings due. If you have a machine at home, please text me your reading. And I started to get these handful of messages back, which is exciting. I thought, hang on, people are engaging with me. They're responding. This is really good. They're engaging, and these readings are good. And if they're a bit high, just contact patients. And these are patients who haven't engaged in years, right? So no one's seen them for 18 to 24 months. And they sent a message back. We're like, oh, okay. Well, you need some medication, or actually that's fine. So it was really good. So I was achieving something. I didn't need an admin person to contact. I didn't need a nurse or an HC. I was just doing it myself. Yeah. It was inefficient, but he was doing it myself. It was just easy. And then AccuRx changed and they had bulk messaging.
Okay.
So then I bulk messaged a group of patients, and lots of patients messaged back. Yeah. And if you look at our stats, suddenly our readings went from here to like 80% recording, like in a couple of weeks. It was that dramatic.
It was that dramatic.
Really that dramatic. Yeah. And there was a big panic around, how are you going to manage all these readings? But we had the AAR scheme, we had practice pharmacists coming in, and I'd employed and mentored pharmacists through the independent prescribing diploma, specifically focusing on hypertension, diabetes, hyperlipidemia, so that they could manage cardiovascular risk. And it was a really well-defined area that actually, once I taught them, well, this is the approach we're going to take, they started to do it as well. And our readings just became... And now, to be honest with you, I talk about it, but I'm just not involved. Yeah. There is a member of staff sending out the text messages. There's 2 or 3 pharmacists managing those blood pressure readings. But all I know is when I go to a meeting, my data is just so much higher consistently and hypertension than anyone else's, and I feel, oh, this is fantastic. Like, this is nice to know.
So it's an established service that's now there, but it came from the opportunity that you saw AccuRx, and then the bulk emailing, the bulk contacting, and was the response from the cohort quite incredible? Because I imagine that some people might say, well, these people are lost. You know, they don't care about their health. They're not interested. What made you think differently to that? What made you challenge that potentially and think, well, actually, I'm just going to give it a go?
I genuinely, just from being in the town, one of the benefits about, I guess I was, you could say I've got the best of both worlds. So I had enough pre-pandemic experience in the old world, home visits, face-to-face, FaceTime with patients, you know, I know the roads where people live really well. I had enough experience to know, and I grew up in Slough, so I grew up in this area. So I had enough experience with the general public to know, I think this is right. I think they do have a lot of blood pressure machines actually around, and I don't think I need to give anyone a blood pressure machine or send them to the pharmacy. It was my theory. And that's how I tinkered. So that's how I knew that would work. And then the results just spoke for themselves, and people just started engaging, and they just started sending me their messages back. But also, people are working, right? People are busy. They don't want to come and look for parking just for someone to send them a blood pressure, just to check their blood pressure for 5 minutes. Oh, a headache for you. It's like 2 hours out of your day when you could just send me your reading now, and I can just tell you what to do. The key to it was obviously being responsive. So I didn't just ignore high blood pressure readings. We contacted them and said, no, you need to check it for 4 days or 7 days. But it doesn't take very long to say, hey, actually, that reading's high. Can you just check it again? Or actually, you're taking this medication. Let's just increase the dose. Is that okay? Yeah, cool. And then we'll see. You know, that's what you want when you're working, isn't it? Someone who cares about you but doesn't want to long your day out.
No. Was that using telehealth? Yeah. So it's telehealth, digital health. It's all digital.
It's all digital. It's just a text messaging service.
And I guess the fact that if they don't have a blood pressure machine, they can go and pick one up from a pharmacy for probably less than £25.
Oh, and now, again, it's a conversation. I don't think people believe me, and I think we need... So now when I'm in clinic, every so often I'll see someone with high blood pressure, maybe face-to-face, and say, look, tell you what, you've got 2 options. You can come back here for blood pressure reading, because actually we do have capacity, because most people are just monitoring it, and I'm happy to do so. But you're working. Or if you just go and buy one, I can just send you this text, and I can send it to text on any day you want, and you can just send me the readings, and someone contacted you. Oh, doctor, I'm just going to pick it up on the way home. Like, why would you not? Right?
Yeah, why would you not? Because parking's a nightmare, right? So it's just it alone.
Why would you make an appointment?
It's the time out of your day, isn't it? And I think a typical hypertensive patient is much older, so therefore they'll need someone to come with them who might need to take time out of their day, and you're just helping society along a little bit, aren't you?
You are.
With something quite simple as a text message and taking a blood pressure reading at home. If you advise them how to do it, there are plenty of videos on YouTube. Yeah. They're not going to have that kind of white coat syndrome either, so it might be a more natural reading, and taken over multiple period of time. Yeah.
Exactly, you're absolutely right. So home BP readings are actually one of the tests we use to clarify whether someone actually has high blood pressure. So you can send a link that they upload 7 days worth of readings, and we get all the 7 days, and the average is just saved onto their patient record. Yeah. So the data then is automatically coded, and then my data then just looks good because of it. The key thing about that, look, is the fact that, and this is where the challenge is, the opportunity was there, so we've discovered it. The challenge for us is embracing that on a national scale, to say, look, it's okay to ask someone to invest in their health. We're not asking them to go and make us money. We're asking them to stop them having a heart. We're asking you to stop you having a heart attack, right? All you have to do is engage with us. If you don't want to check your own blood pressure, that doesn't bother me. But come and see us. and get your blood pressure checked. Engage with us when we're engaging with you. And if it means buying a blood pressure machine, I mean, you're able to, then just do it, because it will just help you in the long term. What we're seeing now, even if you take hypertension out of the picture, I sent about 1,000 texts for medication reviews. Can you answer some questions about your medication? I've got a response rate of about 20% in an hour.
That's
People
incredible.
are telling me what they're taking, they're okay with the medication, they're uploading their blood pressure, their weight and height. I was just shocked with it. The readings are coming, it's exciting. Primary care has never been more exciting because people are engaging with us in that way. But it's trying to, our role is trying to explain to people who may be just not believing us, or maybe thinking that, a bit sceptical, is to say, look, this is about investing in people. This is about education, investing in people. It's about realising that we don't have many GPs coming into the system. It's an NHS, its resources are thin. So this is the best way in which we can then work with everyone. So we want to recreate what our fathers and forefathers have did, who were out there in the community with the hat and the coat and the digital GP, but could we do this at scale? The Robocop model.
Bharan, I know we're pressed for time. Let's call this part one. It'd be great to come and see you again and meet and talk about the Robocop model, because I'm very excited about that, but also the social care element as well. And I know you're doing a lot with social care in the region. It'd be really good to explore that. So we'll come back, we'll have a chat again, and we'll do a part two, and we'll talk about Robocop and all those other things that is just fascinating. So thank you ever so much for your time.
Thank you, thanks for having me.